morning, everyone. Today I am going to take a class on approach to macrocephaly and microcephaly. Alright. So macrocephaly, the definition goes by more than 2 standard deviation above the mean for age and sex, or more than 97 percentile for the age and sex, or more than 2.5 centimeter above the mean for age and sex. So how to find out the expected head circumference for a particular child? So this can happen only by comparing the standardized charts which shows the head circumference for a particular age and sex. So first you have to measure the head circumference and then you compare the standardized charts which shows the head circumference for that particular age and sex. So this is the head growth chart showing the impaired growth or secondary microcephaly. This is an example where you have age in the x-axis and then the y-axis you have the measurement. So here in this you plot and you make out the any significant difference. So this is the normal head circumference at birth. When the child is less than 3 months, the growth is expected at birth it is 33 to 35 centimeters. At less than 3 months, the growth rate is around 2 centimeters per month. 3 to 6 months, it is 1 centimeter per month. And 6 months to 1 year, it is 0.5 centimeters per month. At 1 to 3 years, 1 centimeters for every 6 months. And 3 to 5 years, it is 1 centimeter per year. So when you see the head circumference is rapidly increasing in the first 1 year of age. So after that, the growth actually slows down. And also remember, at birth, the head circumference is 33 to 35 centimeters. So this is how you measure the head circumference. From the frontal to the occipital. Fronto-occipital circumference you measure. That is head circumference. And always remember, you have to do the overlapping method. So these are the macrocephaly causes. So when it comes to macrocephaly, the causes could be either because of the big skull, maybe the brain is bigger or more CSF in the ventricles or any abnormal accumulation. The other cause could be familial, meaning the parents will be having a bigger head and so does the child. So big skull, the causes could be chronic hemolytic anemia or it could be rickets also. Then the big brain could be megalencephaly like Tay-Sachs disease or cerebral gigantism. More CSF in the ventricles when it accumulates, you have to think of hydrocephalus. And any abnormal accumulation of the fluid, that could be because of subdural effusion. And familial causes commonest at the community level. Here the parents will be having a bigger head and the children also have a bigger head. So here you go according to the causes for macrocephaly. So the commonest thing that you have to rule out is familial macrocephaly, in which case you measure the head circumference of the parents also. So do not forget to measure the head circumference of the parents. Next comes hydrocephalus. Hydrocephalus, the Greek word meaning water in head. So it is nothing but fluid accumulation inside the head. So the definition being excessive accumulation of CSF in the ventricular system, either because of increased production or because of decreased reabsorption. So this is a common causes for hydrocephalus. In most cases, it is because of obstruction and very rarely there is increased production of the CSF. So coming to the normal CSF parameters. So normal volume of the CSF. So in newborn it is around 24 ml at any point in time, and the adult the normal CSF value is around 150 ml at any time, and in 1 hour it is around 24 ml is being produced. 24 ml of CSF is being produced. So normal intracranial pressure. In newborn, it is 10 to 20 centimeters of water. In infants, it is about 20 to 80. And in older children, it is about 40 to 100 centimeters of water. So hydrocephalus. normal CSF. What happens? How the CSF is formed? So let us look at the anatomy and physiology of the CSF production. So the choroid plexus in the lateral ventricles. So these are the site for production of the CSF. The choroid plexus in the fourth and the third ventricles as well as the capillary endothelium. CSF, I want you people to remember, it is nothing but the ultrafiltrate of the plasma. So it is the ultrafiltrate of the plasma produced by the choroid plexus in the lateral ventricle, third and the fourth ventricles. So how does the CSF circulate inside the skull and the spinal cord? So going to one by one. So this is the normal CSF pathway. So first it is in the lateral ventricles, then it goes to the third ventricle. After that, through the aqueduct of Sylvius, it goes to the fourth ventricle. Then it goes to the arachnoid villi and it gets reabsorbed in the villi. So this is how you have to remember the pathway, starting from the lateral ventricles, third ventricle, fourth ventricle, and it goes to the arachnoid villi and the subarachnoid space. This is the normal CSF pathway. So this is a CSF pathway in detail. CSF is formed in the lateral ventricles and it goes to the third ventricle. It goes to the third ventricle through the foramen of Monro and then it goes to the fourth ventricle through the aqueduct of Sylvius and into the subarachnoid space of the spinal cord through the foramen of Laschke and Lachandi. So this much I want you to remember when it comes to the pathway. From the lateral ventricles, it goes to the foramen of Monro, then aqueduct of Sylvius, then into the subarachnoid space of the spinal cord through the foramen of Laschke and Lachandi. So how is the CSF normally absorbed? The CSF is normally absorbed through the arachnoid villi and through the lymphatic channels. After the passage, it is absorbed by the arachnoid villi and the lymphatic channels. So there are three mechanisms predisposing to the development of hydrocephalus. First is increased production. So increased production leads to communicating hydrocephalus. Decreased absorption, that again leads to communicating hydrocephalus. Obstruction most commonly in the aqueduct. So it is a normal aqueduct anatomy is 3 millimeter long and 2 millimeter wide. So once there is obstruction, it can be either obstructive, that is most commonly it is non-communicating hydrocephalus. So increased production of the CSF. Let us go one by one. Increased production is tumors of the choroid plexus. Choroid plexus papilloma. It is quite rare actually. Tumors is quite rare. So the commonest cause will be either decreased absorption. This can happen because of obliteration of the arachnoid villi and cisterns. So like common reasons could be congenital infections like horse infections, acquired like meningitis and leukemia. So the next, the commonest thing comes obstruction to the CSF. So obstruction to the CSF is either congenital, that is aqueductal stenosis, like torch infections, malformations of the aqueduct, aneurysmal dilatation, that is vein of Galen malformations, or it could be X-linked congenital per se. Then the other causes could be Arnold-Chiari malformation type 2 and Dandy-Walker syndrome. So these are the congenital causes for CSF obstruction, which in turn leads to hydrocephalus, aqueductal stenosis, Arnold-Chiari malformation type 2 and Dandy-Walker malformation. So this is the Arnold-Chiari malformation type 2. It is nothing but downward displacement and hypoplasia of the cerebellum, obliteration of the cisterna magna. So there is downward displacement of the cerebellum, which in turn leads to obliteration of the cisterna magna. And here comes the Dandy-Walker malformation. So failure of development of the roof of the fourth ventricle. This is all about Dandy-Walker malformation. Failure of development of the roof of the fourth ventricle, cerebellar hypoplasia, cystic dilatation of the fourth ventricle, and associated anomalies of absence of corpus callosum. So these are the Dandy-Walker malformations components. Mainly remember, there is failure of development of the fourth ventricle along with cystic dilatation of the fourth ventricle. So here the picture shows the Dandy-Walker malformation that you can see in the posterior fossa. There is cerebellar hypoplasia and there is a big cyst formation. Alright, then coming to the acquired causes of hydrocephalus. So aqueductal gliosis. Aqueductal gliosis can be either because of meningitis or bleeding like intraventricular intern or mumps encephalitis, or it could be posterior fossa tumors like medulloblastoma obstructing the alveoli. So the common causes as you are seeing is meningitis, sometimes encephalitis or bleeding. Posterior fossa tumor could be another contributory cause. Coming to the pathophysiology. Obstruction to the CSF leads to reversal of ventricular fluid into the periventricular white matter, which leads to demyelination and progressive gliosis. So, which in turn leads to damage to the periventricular white matter and later gray matter. Okay, so all this because of the backflow or reversal of the CSF fluid because of obstruction. I repeat again. Thus, there is obstruction to the CSF flow, reversal of ventricular fluid into the periventricular white matter, demyelination and progressive gliosis, damage to the periventricular white matter and later gray matter. So if anybody has any doubt anywhere, you can stop me then and there and you can ask your doubts. So clinical features before the anterior fontanel closes and after the anterior fontanel closes. The clinical features slightly vary. As long as the anterior fontanel is open, the pressure can be dissipated through the anterior fontanel. But once it is closed, the clinical manifestation is slightly different. Alright. So before the anterior fontanel closes, the head is big. The fontanel is bigger. There is widely placed sutures. Another thing what you can call a sutural separation by at least more than 5 millimeters. Broad forehead, prominent subcutaneous vein. Sunset eyes, that is because of dilated suprapineal recess. This dilated recess impinges on the tectum midbrain, which in turn controls the eye movements. So I want you to remember this is an important sign, sunset sign, meaning maximum amount of sclera is seen but lesser amount of cornea is seen. This is because of the dilated suprapineal recess impinging on the tectum midbrain, which controls the eye movements. Okay. The next important thing is weakness of lower limbs. This is because of stretching and disruption of the corticospinal fibers originating from the leg region of the motor cortex while crossing over the dilated ventricles. So weakness of the lower limbs, stretching and disruption of the corticospinal fibers. So this causes weakness of the lower limbs. So here you can see this is called as the setting sun sign or sun setting sign. As you can see, maximum amount of the sclera is seen and lesser amount of the cornea is seen. This is another picture of sun setting sign. Actually, this picture is more clear. As you can see, more of the sclera is seen. So here you can see this picture is about prominent subcutaneous veins. This is another manifestation of the head is also bigger. If you can take a closer look, you can appreciate the macrocephaly, which is because of the hydrocephalus as well as the prominent veins. So now comes the clinical feature after anterior fontanel closure. That is, since there is no area to dissipate the pressure, the intracranial tension arises. So the clinical manifestations are headache, vomiting, blurring of vision. There is stooping and bending can be there. So that leads to blurring of vision. Bradycardia, hypertension, that is Cushing's triad. Okay, then sixth nerve palsy, which is often unilateral. Then papilledema is there, particularly some of the cases, and transillumination. When there is massive dilatation of the ventricles or a Dandy Walker malformation, the transillumination test will be positive. So always remember, if somebody is coming with a bigger head, headache, vomiting, or in suggest of pushing straight like bradycardia, hypertension, and transillumination test being positive, always think of hydrocephalus, the possibilities. So this is the transillumination test that you can see. The frontal and the occipital area, you can see the transillumination hollow because of the fluid accumulation in the head. Clinical features again continuing. Another one after the closure of the anterior fontanelle is McEwen sign. That is crackpot sound. Significant only after the anterior fontanelle and the sutures close. Small occiput you can see in Arnold-Chiari malformation. Prominent occiput you see in Dandy Walker malformation. So this is one of the clinical signs that you can see elicit in the occiput. All right. So next coming to the diagnosis. So first you take the history, whether the parents are having bigger head. Then you think of familial, or whether it is premature birth or intrauterine infections, intracranial hemorrhage, meningitis or encephalitis. So all these you ask in history. On examination, look for capsular spots, which is a neurocutaneous marker, or it is spinal dysraphism, meaning tuft of hair, lipoma, and angioma. Wide anterior fontanelle, wide suture, sunset sign, and lower limb weakness. Cranial groove can be there, like in AV malformation of the Gallen, vein of Gallen malformations, you can get cranial grooving. Transillumination, that can be there, massive dilatation of the ventricles, Dandy Walker syndrome, and in eyes you check for papilledema and chorioretinitis. Check the history. Most importantly, after birth, see for the gestational age and other immediate complications, suggestive of meningitis or encephalitis. Look at the skin for capsular spots and examine the head properly for anterior fontanelle suture suppression. Sunset sign. Also check for lower limb weakness, which is quite common. Eyes you look for papilledema and chorioretinitis. So always do a fundus examination. X-ray of the skull. So X-ray of the skull in the infant, in older child, and in long-standing cases. So let us see what happens. So in infant there is calcification. So intrauterine infection. Calcification such as intrauterine infection, and there can be separated sutures. Thinning of the floor of the cella, erosion of the posterior cleavage. In long-standing cases, there can be silver beaten appearance, an increase in the convolution markings. Silver beaten appearance is nothing but this indicates increase in the convolution markings. Alright. So these you can see the separated sutures, the silver beaten appearance, and the orbit is also shallow. So this is a classical X-ray picture of the hydrocephalus, X-ray skull of the hydrocephalus. I repeat again, separated sutures, silver beaten appearance, and a shallow orbit. So as and when I am teaching you, I am taking the class. So all of you kindly take notes also. Notes of all the slides. So if you people want me to slow down, I will repeat it once again. So then and there you let me know, all of you. Diagnosis. So USG, a CT scan or MRI. So all this will show dilatation of the ventricles, that is communicating type. In case it is dilated, think of communicating type. Third ventricle dilatation and fourth ventricle alone, it's normal. Then you think of aqueductal stenosis. If I repeat, all the ventricles are dilated, means think of communicating type. If third ventricle and fourth ventricle are normal, think of aqueductal stenosis. So here is the dilated ventricle. Clear-cut picture is shown in the CT scan or MRI scan treatment. So the most important first is you diagnose a case of hydrocephalus by your history, by your examination finding, then you confirm it by your investigation, then you go for the treatment. So initially comes the supportive management. So how will you do supportive management? First you do head and elevation to 30 degrees and in neutral position. So this will bring down the intracranial pressure. Next, you control the temperature. Because temperature maintenance is another important vital. Control the seizures because every time the child is throwing seizures, there is possibility of raised intracranial tension. Maintain the blood pressure. Always give analgesia and sedation if the child is irritable. It's very important because too much pain and irritability also increases the intracranial tension. Next comes hypertonic solution. Hypertonic solution meaning either mannitol or oral glycerol because this also brings down the intracranial tension. Next comes passive hyperventilation. This causes hyperventilation, causes carbon dioxide washout. It also causes mild constriction and the major mechanism for reduction of intracranial pressure. Basically, there is carbon dioxide washout. So this can be tried in ventilated cases. Or even you can tell the child to hyperventilate. For decreasing the production of the CSF, you have to give acetazolamide. It is only a temporary measure. So for obstruction and decreased production, you can go ahead for ventricular peritoneal shunt. This is another definitive procedure. But the problem with ventricular peritoneal shunt is there are certain complications like infection, and the shunt per se can get obstructed. So infection, the commonest organism is Staphylococcus epidermidis, and there can be obstruction. So periodic examination and review of the child is a must once the ventricular peritoneal shunt is being done. So as the name suggests, the fluid from the CSF from the ventricles is being shunted to the peritoneal cavity. So treatment, the other treatment is surgical. Surgical, you can divert the CSF from the ventricles to the extracranial sites using shunt. Like already I have told you about ventriculoperitoneal shunt. The other one is ventriculoatrial shunt. Ventriculoatrial shunt is not being much practiced, but ventriculoperitoneal shunt is commonly being done. So this is the ventricular peritoneal shunt. As you can see, a shunt is being placed in the ventricle, and from there the catheter goes through and through and it is placed in the peritoneal cavity. So from the peritoneal cavity, the fluid is being reabsorbed. So here the common complication is the shunt or the catheter can get blocked. And another common complication is infection, which has to be dealt with by periodic review of the patient follow-up. Alright. So here is a procedure in short, like how you do an incision with the flap, starting with a wormhole. The subcutaneous tunnel is being created after incision, and then it is being placed in the peritoneal cavity. This is ventriculoatrial shunt again, which is not being commonly done, but here the catheter is being placed in the from the lateral ventricles. It is going through and through the internal jugular vein, SVC, and it is placed in the right atrium of the heart, which is not being commonly practiced. So this is a valve that controls the flow of the CSF. It's called the valve. So now coming to the prognosis. So prognosis entirely depends on the cause. Cause for the hydrocephalus or from raised SCT and the rate at which it rises. If it is rapidly progressive rates, the prognosis is not that good, and the presence of other developmental abnormalities like associated brain anomalies or any other malformations. The time at which the treatment is initiated. Suppose early, if it is diagnosed early and if it is treated early, then it is always the prognosis is better. That is the importance of follow-up head circumference measurement in cases of neonatal meningitis. So it's very important whenever there is any intracranial hemorrhage or any bleeding or any neonatal meningitis, you always call the child for postnatal follow-up. And after that, you always measure the head circumference. When the head circumference is increasing beyond the expected time duration or beyond the expected size, then you can early suspect hydrocephalus and you can treat it promptly. So that is a follow-up is very essential in the neonatal post meningitic period, in the post neonatal period. Now coming again the prognosis, it mainly depends on the other abnormalities. So what can happen is developmental disabilities, particularly they can go into poor memory disturbances, visual disturbances, again strabismus, eye defect, optic atrophy. All these are because of pressure related changes. Accelerated pubertal development. This is because of increased gonadotropin levels. This is another problem that you have to anticipate. Next, coming to the microcephaly. So here the head circumference is less than 3 standard deviation. The head circumference is less than 3 standard deviations. So it can be either primary, that is genetic, or it can be secondary, that is non-genetic. So remember, for macrocephaly, the cutoff is 2 standard deviation, and for microcephaly, it is 3 standard deviation. In both, familial causes are most common, and kindly rule out the familial causes before going into pathogenic causes. Next, coming to the genetic microcephaly, the condition associated with reduced generation of neurons during neural development and migration. It refers to the group associated with specific genetic syndromes. Usually, they have slanting forehead. They are identified at birth itself. As you can see, the head is appearing small in this boy. So here we have to always measure the parent's head circumference. So the primary causes being familial, autosomal dominant, and syndromes. Remember Down syndrome? Down syndrome, I am sure all of you might have seen at least once. Friedreich syndrome and Edwards syndrome. Non-genetic causes because of toxic agents that affects the fetus in utero, and also during the particular first 2 years of age. Causes for secondary microcephaly. So here, as all of you know, the causes for secondary microcephaly being radiation, congenital infections like torch infections like rubella, CMV, toxoplasmosis, HIV, and syphilis. Drugs. When the mother is taking either phenytoin or alcohol, meningitis encephalitis can also lead to microcephaly, that's secondary. Metabolic like maternal diabetes, then hypoxic ischemic encephalopathy, malnutrition, and hyperthermia. All these are secondary causes for microcephaly. Approach. Again, you take a detailed history, whether there was any perinatal insult or whether there was any family history. Examine for any dysmorphic features or any malformations, any developmental delay, and growth measurements of head circumference serially. Investigations do a baseline biochemistry and a metabolic screening. Also do a genetic testing like karyotyping and molecular genetics to rule out chromosomal disorders, like example Down syndrome. Also do a torch screening for congenital infections and ophthalmology. You always do a fundus examination and MRI brain to rule out if there is any associated malformations of the brain. Coming to the management. So, unlike macrocephaly, where there was treatment in cases of hydrocephalus, both medical and surgical treatment, remember in microcephaly, nothing much can be done. So, returning to the normal size and shape is not possible. But you can treat the associated problems. Like for seizures, you give anticonvulsants. If there is any weakness, then you give physiotherapy. for any hearing or speech disability, it is speech therapy. And in cases of failure to thrive, you always do a dietary management as well as genetic counseling. Genetic counseling is most important in cases of familial, so that can be avoided. So till now, I hope you people have understood. So any doubts, please let me know. I'm here to clear all the doubts. Anticonvulsants, the commonest anticonvulsant that is used during newborn period is phenobarbital, but after that it is phenytoin. But the newborn period usually microcephaly, unless there is seizures because of microcephaly, we don't treat it, and physiotherapy after that. So always remember to treat the associated problems. So far, I hope it is clear for all of you. So in case any doubts, kindly let me know. I hope all of you will remember the definition. Macrocephaly is 2 standard deviations higher. So I want you to remember why for macrocephaly it is 2 and microcephaly it is 3. The thing is, microcephaly, nothing much can be done. So 3 standard deviations has been kept as a cutoff. Macrocephaly, if you know the cause, something can be done. So early diagnosis is a must. So that's why here if you see in macrocephaly, the definition is being 2 standard deviations. Going back, I'm just putting the slides again. Macrocephaly definition. So remember, it is either 2 standard deviations, 97 percentile or 2.5 centimeters. Yeah, we have to identify it early so that treatment can be given promptly and further damage can be reduced. That's why macrocephaly is 2 standard deviation has been taken as a cutoff. So if there is no doubts, then I'm winding up the class. You can put up a message. All right, let me know.